I don't know why my Zooms keep on quitting. Let's see, I hope it will work. Okay, just something about me. I'm a nurse. I have a background of 24 years experiences in psychiatry, both as a nurse, leader, and researcher. I'm educated as a registered nurse and have a science degree in mental health science and a PhD. And currently I work as a researcher at Mental Health Center St. Hans in Roskilde in Denmark, one of 5 regions in Denmark. And as a start, I would like to just define some things first. First of all, I would like to give you a definition of trauma. And you must remember this is only one of many definitions of trauma. First of all, we mostly in Denmark work with this definition of trauma when we work with the trauma-informed care. And we look upon trauma as a result of an event, series of events or set of circumstances that is experienced by an individual as physical or emotionally harmful or threatening, and that has a lasting adverse effect on the individual's functioning and physical, social, and emotional or spiritual well-being. This definition is from SAMHSA in 2014. And the definition we mostly work with in Denmark when we look upon trauma-informed approach or care is that we incorporate 4 key elements. First of all, or we call them the 4 R's. First of all, it's realizing the prevalence of trauma and then recognizing how trauma affects all individuals involved in the program, organization or system, and that also includes this organization's own workforce. And then as number 3, responding by putting this knowledge into practice and seek to resist re-traumatization of both clients and staff. And I have also taken a definition of trauma-specific services or treatment. And I just want to elaborate on this because it's just to distinguish this trauma-specific services from trauma-informed care. When we talk about trauma-specific services, we mostly refer to evidence-based or promising preventions or interventions or treatment services. For example, trauma-informed cognitive behavioral therapy or some programs called seeking safety or prolonged exposure. There are numbers of interventions that could be put under this definition here. And our aim for our scoping review was our overall research question was, what is known about implementing trauma-informed care? And before we jumped into making this scoping review, we have had a lot of discussion in Denmark. What is trauma-informed care? How can we implement trauma-informed care in mental health services? And our leadership in these 5 regions we have in Denmark, they gave us, and when I talk about us, we formed a steering group, a national steering group on how we could implement trauma-informed care. And this group was given the task of trying to establish knowledge on this area. And then we decided to make a scoping review. And when we started out with this scoping review, we invited some stakeholders. I will come into that later, but we invited some stakeholders to help us with formulating our research questions. And we ended up with a few research questions, but our overall research question was, what is known about implementing trauma-informed care? And as many of you probably know, a scoping review involves a couple of steps. It's important for me to say that we involve these stakeholders even before these 5 steps. We talked with the stakeholders before we began formulating our research questions. And the stakeholders were also involved in formulating the research questions. And after we have formulated a research question, we began to identify relevant studies. We did not involve the stakeholders in identifying relevant studies, and we did not involve them in selecting studies, and we did not either involve them in mapping or collecting or summarizing. But we will later on invite the stakeholders again in formulating some recommendations based on our scoping review. The stakeholders we have involved in all this was 16. Most of them were service users or trauma survivors, staff, managers, or representatives of NGOs, and some researchers. We found in our search after relevant studies, we found nearly 4,000 studies, and we began our screening of these papers, and at the end we included 158 studies, which we began to extract data from. And our results from this extraction of data, we found an increasing number of publications, beginning when we included studies from 2015 and up to February 2022. We saw an increasing numbers of published studies at the end of our search. Most of the studies were from English-speaking countries. As you can see, 92% of our found studies were from English-speaking countries. And we also tried to see which setting were these studies from. And I have tried to numerically order them up here. So most of the studies were from child welfare, educational settings, and primary, secondary care, or behavioral health and community services. And so we found a number of studies from these different types of settings. Also a lot from mental health or behavioral health settings. And a majority of these studies, 146 out of the 158, they included one or more definitions of trauma-informed care. And what we saw were that these studies were using different definitions of trauma-informed care. I presented the definition of trauma-informed care from SAMHSA, and most of the studies we found were using this definition as well. But some also used a definition from Harris and Fallot or Bloom's sanctuary model. And but there were different approaches to trauma-informed care in these studies we found. And most of the studies we found, they have some form of intervention. A little over half of them concentrated on educational interventions, how to teach staff in using trauma-informed care approaches. And but what we also saw were that these different types of educational interventions, they ranged from a brief introduction of 30 to 60 minutes of online training sessions to a more comprehensive training program spanning of several years. And then we decided to try to divide all our findings or interventions into 3 categories. One category was educational intervention alone, and another category was if they have used any other form of intervention, for example, trauma screening, therapeutic activities or supervision of or mindful or engagement training, and then a combination of both educational intervention and other interventions. But we must say we also included a 4th category, papers that did not describe any form of interventions, and nearly 30% of our studies did not include any form of intervention. We tried to divide our findings in service users, and what we found was that the studies that included clinical measures to examine service users were mostly trauma and PTSD screening tools, and the majority of these studies used actually validated trauma measures. Some also used non-validated scales. And we also saw a number of studies that used self-employed generated questions, not any form of validation. And although that trauma and PTSD screening tools were the most commonly used assessment among the service users, there were other measures used as well when they evaluate the implementation of trauma-informed care. And we decided to divide the other type of way to evaluate the implementations into two categories. The first category used data that were observational in nature and primarily collected as part of a routine documentation by, for example, the nurses in the clinical practice. And the second category were included measures used to examine service users' health and well-being, and that was either evaluated by service providers or reported by the service users themselves. And what we also have another way of looking at the results. That was when the staff reported some sort of implementation degree, and most of the studies used a questionnaire to assess staff knowledge and their attitudes in relation to the trauma-informed care training. We found a few studies that examined secondary traumatic stress in service providers. They used, for example, the Professional Quality of Life scale from 2010. We were also interested in look upon the organizations. A number of studies they have investigated barriers and also the readiness of implementing trauma-informed care in organizations. And they evaluated these trauma-informed care programs and assessed the success of implementation at the organizational level. And we found when we looked into how the organization investigate the success of implementation, we found numbers of different number of different tools to do this. For example, tools to look on how staff members looked upon trauma-informed care and how they looked upon trauma. Yes. Our conclusion is that we, as you can remember, we found different types of definitions on trauma and different types of definitions on trauma-informed care, and also different ways of educating into what is trauma and what is trauma-informed care. And so this indicates that this framework is complex and multifaceted. We actually didn't knew this already before we started out with this, but our search here established our knowledge. And what you also saw was that it lacked a unified structure or distinct theoretical foundation to steer both research and practical application. And it has been defined and customized in a diverse manner across various settings and population, employing a range of intervention and assessing different outcomes. This diversity poses some challenge in synthesizing the knowledge of trauma-informed care and the use of trauma-informed care. And we think there's a pressing need for more extensive research into trauma-informed care to address this complexity and try to foster a more clear understanding of application of trauma-informed care. Yes, I actually think this ends my presentation for now. Yes.